Okay, how's it going? So, uh, this is the first of a few, hopefully, study sessions that I will. How's it going, Eric? How's it going, Jenna? Um, Hello, everyone else. Like I said, I was getting ready to say this is hopefully a few of many study sessions to come. As some of you might know or maybe not know, I've been having a little bit of difficulty. Um, uh, I've been having a little bit of difficulty passing my board exams. Part of that has to do with pride. One of the main hindrances I feel like in any endeavor that we undertake is pride, and a lot of times we can seclude ourselves and box ourselves away in order to escape from shame. But just learning that we need to just go ahead and confront our fears and confront those things that could be hindering us. So I decided to go ahead and take advantage of the community that I have here and everyone here who's supporting me, and allow you guys to actually help me study for my exam. And so as I get ready to pass these exams, then I can definitely have you guys to help think for that. So we're just going to dive right in. The first session that I'm going to be reviewing is going to be on gynecology. I know, random subject, but hopefully you will find this information helpful for those individuals who might be watching it later, who are pre-med, or if you're interested in healthcare, or any women who are just interested in learning more about women's health. This is going to be a review type session, high level, third year to fourth year medical. Thanks, Eric. Third to fourth year level medical information. Hopefully, I'm going to be able to break things down clear enough so that a majority of you guys can actually understand, keep up with what I'm saying. That's the goal. If I'm not able to explain things in a way that is comprehensible to the general population, then that's an indication to me that I haven't mastered that material to the degree that I actually need to. So I will be Dr. Justin Williams, and whoever created the online meta team. But just jumping right in, we're going to be first talking about gynecological cancers. So gynecological cancers, there's a few of them that are included in this section: cervical cancer, endometrial cancer, vulvar cancer, Paget cancer, disease of the vagina, germ cell ovarian cancer, and epithelial cell ovarian cancers. Thanks, man. Starting from the top with cervical cancer, we're going to look at the pathology, the patient presentation, the diagnosis, what tests you order to diagnose the disease, and treatments. And for some certain cancers, there's also going to be screening involved. And for those women who are more familiar with going to the doctors, you've probably heard of a pap smear, and that's to assess for the risk for cervical cancer. So the pathology, cervical cancer is mediated by a virus, which is called the human papilloma virus vector, which serves as a vector which initiates the cancer process. It changes the normal epithelial cells of the vagina over the cervix to cancer cells, basically. The HPV subtypes that cause cervical cancer are 16, 18, and those serotypes that are in the 30s, so 31, 33, 35. So 16, 18, and 30s are going to be the ones that are thanks. I will let you know if I need anything, Dan. 16, 18, and 30s are going to be the ones that are contributing to your cervical cancer. So the patient is going to present on an asymptomatic screen and on a pap smear. So hopefully we're catching those patients before they ever progress to cancer. They also could present after they started to have some changes that resemble cancer or before they get full cancers, and that could present with a postcoital bleed. So after intercourse, a female might have bleeding. That might be an indication that she could be suffering from cervical cancer, and this will be in a reproductive aged female. Why? Because human papillomavirus is spread via. Oh, and congrats, Mary, on matching. Congrats, in Wellington, in my hometown too. And please ask questions. Hopefully this can be a little bit interactive. If you don't understand something, then I'll be happy to help explain something in a little bit more detail. So diagnosis is on pap smear. I'm sorry, what I was saying is this is a reproductive age female because HPV is a sexually transmitted disease. So you're exposed to the virus by sexual intercourse. Diagnosis is on pap smear, and you're going to start screening at age 21 years old. So no matter what age the patient starts having sex, you're going to start screening them at 21, and then every 3 years after that. If you have a asymptomatic squamous cell changes of undetermined significance, then you're going to reduce that interval of screening to every 1 year. So if you find something that you don't know if it's necessarily cancerous or not, then you're going to want to recheck that that sample or that patient to make sure that they actually are not having cancer. But that interval is going to be every 1 year, and you can do that with a yearly pap or with HPV DNA testing. You're going to use a colposcopy in order to visualize the cervix. The scopy aspect is a word that helps denote that you're going to be using a tool to view the cervix. And then there could be some ectocervical lesions or some endocervical lesions. So if this is the cervix right here, there could be some lesions on the outside of the cervix. I can't do this, it's all backwards. Or there can be lesions on the inside of the cervix. Then you're at that point, you're gonna want to do staging. But if you have ectocervical lesions on the outside, you're gonna do some local ablation, which is some LEEP is loop electrocervical excision, something like that. I can get that to you. But it's also part of it. Also, you're going to do or cryotherapy is for ectocervical cancer lesions, and endocervical. You're going to want to get in there and do a cone biopsy. When it comes to staging, for stage 2A or lesser, you're going to just cut it out, and that's called local resection. Stage 2B or greater, you're going to be wanting to initiate chemotherapy along with that, along with radiation. Again, this is a preventable disease, and so you're going to want to screen that with a pap smear, and you can also prevent it by having the HPV vaccine. And that's going to be given to girls that are age 11 to 26 and boys age 11 to 21. As even though men cannot get cervical cancer, men are able to transmit the vector. So you're going to want to decrease the risk of transmission. Next cancer, endometrial cancer. So the pathology is such that we're going to just remember that progesterone is protective and estrogen is exposure. So exposure to increased risk of endometrial cancer. So as a woman ages, her lifetime exposure to estrogen is increased. So women who are of older age are at greater risk for endometrial cancer. Also, other things that increase the risk of cervical cancer are not having children, not being pregnant. So progesterone is a hormone that increases in pregnancy, and if you've never been pregnant, then you've had a lot of estrogen exposure without that protective progesterone, and so not having kids increases your risk for endometrial cancer. In addition to that, obesity and PCOS, peripheral fat encourages an excess of estrogen. So estrogen is associated with peripheral fat, and that allows you to have increased um, risk of endometrial cancer, as well as hormone replacement therapy. If you're on hormones after menopause, then that increases your risk of um, endometrial cancer as well. So your patient's going to present with a postmenopausal female with postmenopausal bleeding. So after should stop any bleeding after that is a sign of concern. You're going to diagnose this by endometrial sampling, or by a dilation and curettage (DNC) biopsy. Your treatment is going to be if there's a hyperplasia, which means an increased proliferation of the endometrial tissue and of the inner lining of the uterus, then you're going to give them progesterone. And and if they actually have cancer, frank cancer, then you're going to treat them with a total abdominal hysterectomy and bilateral salpingo-oophorectomy. That basically means your uterus and your both ovaries and your fallopian tubes will be removed, and that can be with or without radiation and or with or without chemotherapy. Next cancer is vulvar cancer. The pathology is similar to that of cervical cancer, in which is associated with HPV, and that produces a squamous cell cancer, as well as melanoma. If you have patients who sunbathe and they have exposure to the sun, then that can also be a source of vulvar cancer. Patient's going to present with a black and itchy lesion, and you're going to diagnose it with a biopsy. So you're just going to want to basically cut it out. So both melanoma and squamous cell cancers have the potential to be malignant, and so you're going to want to go ahead and treat it with a vulvectomy, along with lymph node dissection, to make sure that there has not been any metastasis to the local lymph nodes. Paget's disease of the vulva, the cancer. That cancer is usually not invasive. That patient is going to present with a red and itchy lesion. That's contrasted against the vulvar cancer, which is black. But the Paget's disease is going to be red and itchy, and that one is not going to be as virulent or malignant, as aggressive. So you will biopsy that, but then local resection is going to be all you need to just take out that lesion itself. You don't need to have a complete vulvectomy. Germ cell ovarian cancers. So there's different subtypes of germ cell ovarian cancers. Dysgerminomas. You're gonna they can be a result of chemotherapy. I mean, you're going to treat them with chemotherapy, and the marker for that is LDH. There's also endometrial sinus tumors. The marker for that is AFP. So you're going to want to trend those studies in order to assess for resolution. And then the teratoma. And then all the doctors who've joined, please continue, keep me honest. Please, I welcome you to keep me honest if I say anything that's incorrect. This is a learning experience. So, and teratoma, struma ovarian, those present with symptoms of hyperthyroidism. So you can potentially have a patient who has hyperthyroidism. You want to assess for the possibility of them having a germ cell ovarian cancer. On also a choriocarcinoma, which those markers are going to be a beta HCG. And so the pathology for these germ cell ovarian cancers are such that they're non-malignant. And the patient could present as a teenage girl with adnexal mass. So if a patient has a mass in her lower pelvis, in a teenage girl, that's a patient population in which you should be concerned about a germ cell ovarian cancer. So diagnosis, and it's going to be stage 1 because these are non-malignant. They're not going to be likely to spread before you observe them, before they present with symptoms. The patient's going to present. Sorry, diagnosis is going to be on a transvaginal ultrasound, but that's going to be confirmed with a biopsy. Treatment is going to be a unilateral salpingo oophorectomy, and that's going to be a conservative treatment. If you have a patient who is either in her teens or she's not done having all the children that she wanted to have, then you're only going to take out only one of the ovaries and uterus and fallopian tubes to allow for them to have the opportunity to continue to try to get pregnant with the remaining ovary. Next cancer is the epithelial cell ovarian cancer. Different subtypes of this include the serous, mucinous, endometrioid, and Brenner's tumors. And the pathology with epithelial cells is that there's epithelial trauma. So the ovary is epithelial tissue, and each time a woman ovulates, there's localized trauma to the ovary, and that trauma can eventually cause irritation that could start the cycle of progressing to cancer. The patient's going to be a postmenopausal female with null or low parity, and in that postmenopausal female who had few or no children or was pregnant few or no times. Stage 3B or worse, even with the screen, that's going to be how they present. So the patient, the pelvis has a lot of room in it to grow, for a cancer to grow without it actually causing any problems or interference with the patient's life. And so by the time they actually present to the doctor, they're going to potentially present with actually malignancy or spreading. They can also present with renal failure if it obstructs the ureters and causes a backup of the urinary tract, and as well as ascites, which is fluid that is produced from the cancer tumor itself. The diagnosis, you're not going to screen for these cancers because they're rare and because it wouldn't even be beneficial to screen for these cancers. But when you do diagnose it, the first line is going to be via a transvaginal ultrasound. And then you're going to use a CT scan to stage the cancer to see how far it has spread. And then in order to track it, you're going to track with the tumor marker CA125. But the best way to determine if it indeed is a epithelial cell ovarian cancer and what subtype it is by biopsy. Your treatment is going to be total abdominal hysterectomy with bilateral salpingo oophorectomy, along with the chemotherapy agent paclitaxel. One thing to note is that the BRCA1 or 2 screen, so if you have a patient who has the tumor markers BRCA1 or BRCA2, they have an increased risk for this cancer. So you can have a transvaginal ultrasound to screen those patients, and also do a CA125 to assess whether that patient has potentially early stages of this cancer, but there is a potential for there to be a prophylactic total abdominal hysterectomy with bilateral salpingo oophorectomy at age 35. Continuing on with the gynecological cancers, you have the stromal cell ovarian tumors, and there's 2 types of these: granulosa theca and Sertoli-Leydig cell tumors. Granulosa theca cell tumors secrete estrogen, so you're going to have perhaps in a young patient who's pubescent, precocious puberty, which means that puberty starts before the intended age, age appropriate. Or you can again have sertraly Leydig cell tumors. These are going to present with they're going to secrete testosterone, in which you're going to have the masculinization or the virilization of a patient. And these are going to be in patients who are more likely to be, they're more likely to be postmenopausal women. So these are grown women at this point. And then vaginal cancers themselves. So vaginal cancers, there's squamous cell carcinoma, just like cervical cancer, except you're not going to be able to actually do a pap smear to look for that. Um, and then the adenocarcinoma, one thing to keep in mind is that DES exposure in in the patient's mother, while the patient was in her mother's uterus, puts that patient at risk for this type of cancer. So there was a medication called DES. I don't remember what it stands for, but it was used a while ago, and it was given to moms while they were pregnant. And those female babies who were exposed to DES while they're in their mom's stomach, those patients have an increased risk of adenocarcinoma, and as they age, and that's going to present with a grape like mass, and that is in the vagina, and that can potentially um, present to you as a child. But at this point, I do believe that the majority of the patients who are exposed to DES are a little bit older, so it's unlikely that you'll have a child who has been exposed to DES in utero. Hi, Dr. Carmen. Dr. Carmen is Proctor is a OBGYN resident, so she will definitely keep me honest here. Now, gestational trophoblastic malignancies, there's a few things. Um, One is the complete mole, an incomplete mole, and choriocarcinoma. So basically, there are products of conception, whether um, it's actually an actual fetus that ends up being viable and coming to full term and being a child. That's one potential product of conception. There are other products of conception that could potentially not be viable and could potentially end up being um, cancerous in that uh, these are these are highly mitotic cells, in that they have a high turnover. They replicate very, very quickly, and sometimes those things get out of control. And so uh, one such case is a complete mole. So if a complete molar pregnancy, you're not going to have any fetal parts. It's going to be completely chromosomal. It's going to have chromosomes that are going to mimic a normal child, and that's 46 chromosomes. And in this case, it's going to be XX karyotype, and it's completely spermal. So you have basically two sperm eggs who fertilize two sperm, not sperm eggs, two sperm who fertilize an egg that does not contribute any genetic components to that product of conception. So the fertilization is normal, but the egg is broken. The patient is going to present with size for dates discrepancy. So a normal pregnancy the baby will grow at a certain rate, and in this case, the mom will have a growth rate that is greater than that which is expected for a normal pregnancy. The beta HCG also increases at a certain expected rate, and if that rate increases too much or too high, that could be a sign that this could be a trophoblastic pregnancy. So the beta HCG will be way too high. Having too high beta HCG is going to present with certain traits is going to have certain symptom or sequelae, and that includes hyperemesis gravidarum, so a huge amount of vomiting, like very, very, very bad morning sickness. Hyperthyroidism is a result of beta HCG, and yeah. So this can also present with as an adnexal mass. You'll see this as a simple cyst. It's going to be homogeneous and can also look like grape-like mass exiting the cervix. So I feel like I want to show this to you. I'm going to find complete molar pregnancy. I'm going to show you what some images of this. And I'm going to be able to, I should be able to share my screen at some point, right? I don't know how this works. Dang. Okay, so I can't share my screen. Well, I don't at least know how. But Google complete molar pregnancy, and you'll get a chance to look at what that looks like. It's really gnarly looking. But let me know if you looked it up and tell me what you think of those pictures. On diagnosis, because there are a bunch of small little grape-like lesions on ultrasound, you're going to see it. It's going to have a snowstorm appearance on ultrasound, and the treatment for that is going to be a suction curettage. You're going to have to take that out of the mom. You're going to follow up with a beta HCG every week. So you're going to, as you take out the trophoblast, you take out the molar pregnancy, you have to trend the beta HCG to make it sure that it goes all the way down. If it goes back up, then before I get there, and then you're going to also put her on oral contraceptive pills. You're going to want to do that to make sure that you continue to trend the HCG all the way back down to distinguish it from a potentially normal pregnancy. If the patient is not on contraceptive pills and the HCG goes back up, you don't know if that's a normal pregnancy that's coming back or if that's the molar pregnancy that is starting to get out of control again. An incomplete mole, as contrasted from a complete mole, is going to have some fetal parts into it. The other complete mole was completely molar, no fetal parts. This has some fetal parts. It's incompletely chromosomal, so it does not have the normal karyotype that is appropriate for sustaining life, and so it's going to have three things contributing to that chromosome. So 2 sperm and 1 egg. So 3 times 23. Yes, 3 times 23 is 69. So you're going to have a patient who has. How do you differentiate between a complete and partial molar pregnancy? Awesome. So on karyotype, for incomplete molar or partial molar pregnancy, you're going to see a karyotype of 69XXY. So it has 2 sperm and 1 egg. So the karyotype is XXY. So almost like, yeah. So abnormal fertilization, which includes 2 sperm, but the completely chromosomal, the gestational, the complete mole has a 46XX karyotype. It's going to look pretty much the same on diagnosis. You're going to have the ultrasound with the snowstorm appearance, and you're still going to have a lot of the other physical symptoms in the incomplete mole as you do in the complete mole. So you're going to have the size for dates discrepancy, the beta HCG levels that are too high, the hyperthyroidism from the beta HCG, hyperemesis, and adnexal mass, and the great white mass exiting the cervix. So it really doesn't matter what Um, it doesn't matter what if if beta HCG is down to 0 every week, and you're going to put that patient on OCPs for 1 year. And then choriocarcinoma, this is a little bit different in that this is a cancer of the gestational contents. And so after you have um, a molar pregnancy, or after you have an ectopic pregnancy, or even a normal pregnancy, there can be some cells that end up growing out of control, and that can potentially present with you with a choriocarcinoma. And you're going to have the same high beta HCG with those associated symptoms as I previously talked about. And diagnosis first is going to be on a transvaginal ultrasound, and the best diagnosis modality is going to be a biopsy, and that's going to be via curettage. So just going in, kind of scraping everything out, basically. And then you're going to want to stage it. So you're going to get a CT scan to make sure that it did not spread. And then treatment is surgical. So total abdominal hysterectomy is first, and then debulking, because this is a aggressive tumor. So you're going to want to try to take out as much as possible. And then some medical treatment is going to be MAC. I'm going to write this down because this is something that I need to really get. So MAC, that's methotrexate, actinomycin D. It's not really spelled right. And cyclophosphamide. And then chemotherapy with that MAC backbone for advanced disease. So that's the majority of GYN cancers that they go over in online med ed. This took a little bit longer than I thought, but let me ask you guys kind of, you call it EMACO. What, Dr. Proctor, what is EMACO? That's MAC. Okay. So let me ask you guys kind of what you guys want to learn about. So going from here, we have incontinence. So different types of conditions that can present with the inability to retain the control of your bladder in women. Adnexal masses, which are masses of the lower pelvis and the fallopian tube. Pelvic anatomy review, GYN infection. So for those individuals who are like infectious disease, abnormal bleeding, amenorrhea, infertility, menopause, or virilization. Does any of those topics sound good to you? Amenorrhea, which is losing your period, vaginal bleeding, abnormal vaginal bleeding, that's a big topic. Gynecological infections, pelvic anatomy, and adnexal masses. All right, so Dr. Proctor is helping us out. She said that they call it EMACO. So that's etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. Ooh, thank you for that. I'm gonna write that down. We got 1 vote for bladder, and you're winning, Fatima, because you're the only one that answered so far. And we have Jenna with amenorrhea. I like amenorrhea. That's very important. What's the #1 cause of amenorrhea? Guess. As I write down EMACO. So 1 vote for amenorrhea, 1 vote for a bladder. Then Christine is AKA oncocorin. Yeah, I was wondering. I was like, "Where's the O and why is the V?" Low body fat. That is a cause. Number one cause of amenorrhea is pregnancy. So that is the most common cause that a woman stops having her period. Um, let us continue with let's continue with amenorrhea. Fatima, I got you with that incontinence. So amenorrhea. So there's a difference between primary amenorrhea and secondary amenorrhea. Primary amenorrhea is if a patient has never had never had a menses in her life. She's never gotten her period ever. Secondary amenorrhea is if a patient has previously had a normal period and then has subsequently stopped having a normal period. So different causes of primary amenorrhea. First, there can be grouped between there's constitutional and common causes, craniopharyngioma and Kallmann, which is basically a pituitary lesion, Mullerian agenesis, Turner syndrome, and androgen insensitivity syndrome, which are developmental changes. Some of them have to do with chromosomal abnormalities, and in which some of the normal parts that are required to actually have a healthy period healthy female anatomy have never actually developed. So primary amenorrhea, so the pathology is going to be in the axis. So the hypothalamus pituitary axis. So the hypothalamus is a part in your brain that communicates with the pituitary gland, which is another part of your brain. And the hypothalamus sends signal to the pituitary gland, which then signals to the end organs that tell them to react or respond in a certain way. And we're talking about hormones when you talk about signals. So this is primary amenorrhea is associated with the development of, or the lack of development of, appropriate secondary sexual characteristics. So if you have an intact HPA axis, you are going to have breast development, appropriate secondary sexual characteristic development. But if you have an anatomical issue, the issue is going to be with the uterus itself. It's going to be at the level of the uterus. A patient who doesn't have secondary sexual characteristics by age 13, along with primary amenorrhea, along with amenorrhea, is going to pique your interest to dig a little bit deeper, and then and as well as no menarche by age 15. So if you have a patient who's 13 years old and she has started to have breast development but hasn't gotten her her menarche or her first period yet, then they have until 15 in order to get their period before you start having raising concern. But if they haven't even had breast bud development yet by age 13, then you're going to want to start doing a workup. Diagnosis is going to be with a urine pregnancy test. As Jenna remembers, the number one cause of amenorrhea is pregnancy. So it could be possible that the patient actually got pregnant before she ever had her first period. So you always want to rule out pregnancy. And then you're going to do a risk X-ray, and that's going to look at the bone age. So if a patient has a mature bone age or an immature bone age, that's going to give you information about their constitutional development, if they're on track to develop normally. And you're also going to do an ultrasound of the uterus. And the treatment is going to be disease specific. So some constitutional and common causes of primary amenorrhea is the disorders of the hypothalamus. The hypothalamus controls everything. That's what they have written here. The patient's going to present in a myriad of ways, potentially an anorexic patient who has that psychological disorder, and they're underweight, might not ever get their period, as well as weight loss or intense exercise. That's what we were talking about, Jenna. The decreased body fat or increased exercise can cause your period to stop. And again, pregnancy before the first period. Diagnosis is first is with a urinary pregnancy test, and that's going to be and then also it's a clinical diagnosis as well. If you don't see breast bud development, then they have a growth delay. And then you're gonna reassure them if they're just behind developmentally, and you allow them to catch up. Or if you suspect that they are pregnant on the urinary pregnancy test, then you're gonna want to do an ultrasound. Next cause is a craniopharyngioma or Kallmann syndrome. So these are disorders of the brain. Craniopharyngioma is a type of cancer of the pituitary gland. The pathology is in the hypothalamus. The patient does have a uterus, that's fine. They do not have normal breast development, and they would not have had menarche yet, so they wouldn't have had their first period. You're diagnosed, when it comes to diagnosis, you're going to get a FSH and LH, and you're going to look at that ratio. So a FSH LH ratio that's decreased is going to give you concern for either a craniopharyngioma or a Kallmann syndrome. And then you're going to do an MRI. If you do the MRI and there's no mass, then you want to think about Kallmann syndrome, because the craniopharyngioma is a tumor in the brain. If there is a mass on the MRI of the brain, then it's likely going to be craniopharyngioma. The treatment is going to be estrogen and progesterone in order to help with that maturation process. And then for craniopharyngiomas, you're going to want to resect them. Also, interesting to note, this is going to be a key clue on examination questions, is that Kallmann syndrome is associated with anosmia. So a patient doesn't develop the ability to smell properly. Another cause of primary amenorrhea, Mullerian agenesis. So you have a female who is genetically female. She has XX chromosomes, and there's an idiopathic loss of Mullerian ducts. So Mullerian ducts are, when it comes to embryogenesis and the development of the patient in their mother's womb, the products of the Mullerian ducts, which are you don't actually have them in the adult patient, and they're part of the process of development of the female anatomy. But if they do not develop or they're lost, then you don't develop your uterus properly. This patient will have secondary sexual characteristics, and they will have normal external female genitalia, but they will not have the uterus, fallopian tubes, or the upper 1/3 of the vagina. So the uterus, fallopian tubes, and the upper 1/3 of the vagina are the result of the Mullerian duct. So if those do not develop, then you won't have a uterus, no fallopian tubes, or upper 1/3 of the vagina. It's going to be a blind pouch. Diagnosis, first diagnosis is on ultrasound, and you're not going to see a uterus. And again, the karyotype when you do genetic testing is going to be XX, and the FSH-LH ratio is going to be normal. So if you have a patient who has not had their period ever, and you do FSH-LH ratio, and the ratio is decreased, then we're thinking about potentially Kalman syndrome or craniopharyngioma. But if they have an FSH-LH ratio that is normal, then it could be potentially Mullerian agenesis. So you might want to get some genetic testing done. The treatment is to elevate the vagina and to adopt, and they cannot get pregnant. I don't really know what they mean by elevate the vagina. It's possible that they mean to expand the vagina, because the vagina is going to be shallow, and that could be potentially be just so that they can have a normal sexual life experience. However, they cannot actually get pregnant from, as they do not have a uterus or fallopian tubes. And then Turner syndrome and androgen insensitivity syndrome. Turner syndrome, patient has streak ovaries, so their ovaries are not completely developed. Genetically, they're going to be an XO chromosome karyotype, and they're going to have a couple of other distinguishing characteristics. One of those is a web neck, so they're going to have like a wide neck, web neck, broad spaced nipples, and they also have some cardiac issues. Classically, a coarctation of the aorta is going to be is highly associated with Turner syndrome. Diagnosis is on ultrasound. You're going to see a uterus, and you're going to see ovaries, but they're going to be streak ovaries. And again, the karyotype is XO. And the FSH-LH ratio in this case is going to be high. Treatment is going to be estrogen and progesterone, and that's going to be so that the patient can develop as normally as possible. And because this is associated with cardiac issues, namely coarctation of the aorta, you want to evaluate them for that, so they can potentially treat them before it becomes an issue. So you're going to do that by ordering an echocardiogram to visualize that. That was Turner syndrome. Now, androgen insensitivity syndrome. Now, this is a patient who is genetically male. So they have XY chromosomes, and they do have testes. But the testes they're insensitive to androgens. So upon development, all little boys and little girls, while they're in their mother's womb, start off as females, and it is the Y chromosome that is given from the father that lets the developing egg know that no, you're not going to be a girl, you're going to be a boy. So all of that Y chromosome is going to start secreting androgens or testosterone. Androgens are male sex hormones. Is going to start secreting testosterone, and that testosterone is going to tell the little girl egg, stop being a girl, turn into a boy. If that fetus, that child, and that baby is insensitive to the androgens, then they will never know that they're not supposed to turn into a boy. That they are supposed to turn into a boy, and that they're not supposed to turn into a girl. So they're actually going to develop physically what looks like a normal, healthy female, except for a few things. They do have testes again, but they will physically look like females on the outside. The testes are not going to be descended, so they're not going to be. They don't have a scrotum. So they're going to be in the abdomen. The patient's going to present with present secondary sexual characteristics, and they will have female external genitalia. However, they will not have a uterus. So you do need 2 X's to properly have a uterus. I lied. Why did I lie? How did I lie? Because I just told you that Turner syndrome with XO karyotype do have a uterus, but that's the exception. Diagnosis, first going to be on ultrasound. You're not going to see a uterus. Karyotype is going to be XY, and the FSH LH ratio is going to be normal. Treatment also is going to be to elevate the vagina, and then also to remove the testes after puberty. With testes that are retained in the abdomen, there is an increased likelihood that they can potentially put the patient at risk for testicular cancer. And this is, and you're going to remove those testicles after puberty, and follow up on this is just to just be mindful of that this condition, androgen insensitivity syndrome, is was formerly known as testicular feminization. So that was primary amenorrhea. Secondary amenorrhea. There is, I think that this is some interesting stuff. This is a little bit deeper, so hopefully we can all stay together. Some common causes of secondary amenorrhea are pregnancy. Again, urine pregnancy test, you're going to want to have that to evaluate it. Hypothyroidism. You're going to evaluate that by getting a TSH, a thyroid stimulating hormone test. Prolactinoma or prolactinemia can give you secondary amenorrhea, as there's increased levels of prolactin in the blood, or you have a tumor that secretes prolactin, then you have an increased risk of developing amenorrhea. Medications, dopamine antagonists. Dopamine antagonists are used in antipsychotics. Dopamine is implicated in the pathway of prolactin inhibition. So we're going to talk a little bit more about that in a little bit. And then there could be problems with the HPA axis itself. So again, going back to hypothyroidism. So hypothyroidism, if you have an increase in TRH, basic concept to understand is that TRH, thyroid releasing hormone, tells the thyroid itself to release thyroid hormones. So if the thyroid releasing hormone, so if there's low thyroid hormones, then your body is going to recognize that there's low thyroid hormones. It's going to tell the thyroid releasing hormone to increase, so that you could potentially tell the thyroid to release more hormones. So if there's no thyroid releasing hormone, then you're going to have an upsurge of thyroid releasing. If there's no thyroid hormone, you're going to have an upsurge of thyroid releasing hormone. And that upsurge of thyroid releasing hormone and high levels can mimic or can look like other hormones. So that increase in TRH is going to actually stimulate the anterior pituitary to produce prolactin. And that prolactin is going to lead to prolactinemia. The patient's going to present with symptoms of hypothyroidism, and your diagnosis is going to be with TSH and T4. So those are simple, easy tests to order. So you're going to want to rule that out first. So if they present with hypothyroid symptoms, order a TSH or a T4. Even if they don't present with hypothyroid symptoms, order a TSH and T4 to evaluate for amenorrhea, because it could be an easy fix. But you're going to want to order that before you actually order a prolactin level. um, to evaluate, oh, this person, if they have increased or decreased TSH or decreased T4, then you know what their cause of prolactinemia is. Your treatment is going to be to treat the hypothyroidism, and that's going to be with levothyroxine. Antipsychotics, as I said, are associated with the dopamine pathway, which inhibits prolactin production. So dopamine antagonists disinhibit prolactin. So if you have, so the normal pathway is such that you have dopamine, and dopamine inhibits prolactin. So dopamine inhibits prolactin. If you inhibit the inhibitor, then the prolactin will get out of control. So if this is prolactin and this is dopamine, if dopamine inhibits prolactin and you get rid of this, you'll have a lot of prolactin. Makes sense? So what inhibits, what causes for an inhibition of dopamine? Antipsychotic medication. So a lot of patients who might have schizophrenia or mood disorders who are on antipsychotic medications, they are going to present with potentially present with prolactinemia. Now, in this case, sometimes the patient's schizophrenia is of greater concern than the little bit of milk discharge that might and amenorrhea that might result from having too much prolactin in their blood. And they might be able to just tolerate the side effects as opposed to, reverting back into frank psychosis, which is associated of schizophrenia. So either they're going to tolerate the side effects, or you can change the drug. Again, pregnancy, check the urine pregnancy test to assess for amenorrhea. And then look at hypothalamic causes. The hypothalamus controls everything again. So patients who are anorexic, have weight loss or extreme exercise could potentially have a second amenorrhea. Prolactinoma. Prolactinoma is a pituitary adenoma. Adeno means glands or secreting. Oma means mass or proliferation of. So you have a proliferation of tissues that are secreting substances that are associated with the pituitary gland. So the pituitary gland is out of control, basically, and that's going to present with galactorrhea and amenorrhea. You're going to diagnose this by what? Ruling out urine pregnancy with a urine pregnancy test, ruling out hypothyroidism with a TSH. Now, at this point, pregnancies, the patient's not pregnant. They might be euthyroid and not have hypothyroidism. And so at this point, you're going to look at prolactinoma. Everyone say hi to my girlfriend. Say hi, Kyra. Say congrats on getting into medical school at Howard, Kyra.
Thank you. This is my big too.
And everyone say hi to her dog that I was dog sitting. Jade. This is Jade.
I got a lot of viewers on there.
Well, there's only one viewer right now, but I guess people come and go. So that's all right. Okay. Thank you. You had a good day?
Yeah, it's okay.
Okay. We'll talk soon. Are you going to leave? I'm probably going to be done in a little bit. I don't know about 10 minutes. I don't know about no 10 minutes.
Okay. Well, keep telling me. I'll talk to you.
Okay. Sorry about that. So I'm probably going to leave soon. But this was a good start. But I'm only going to finish the secondary amenorrhea. And then I'm going to potentially have another session to go over some other topics, and then maybe do some questions with you all. You guys are helping me stay accountable. I feel everyone who's joined so far, I feel the love. I appreciate you guys at least taking the interest out to check it out, even if you aren't able to stay for a long time. So, and then let me know what other questions or whatever other topics you want to learn about, because I'm happy to have to study basically everything. So I'm happy to cater my studying to what you guys are interested in learning about. Again, prolactinoma is a pituitary adenoma, galactorrhea, and amenorrhea. So milk expression from the breast, a lack of menses, you're ruling out pregnancy, you're ruling out thyroid disease, and then you get a prolactin level and you see that the prolactin levels are high, then you're going to get an MRI to look for the tumor in the brain associated with the prolactinoma. Treatment is going to be with dopamine antagonists, pramiprazole, ropinirole, and bromocriptine. And then if those don't work, then you're going to do surgery. So the first line treatment is going to be with medications. And then after that, you're going to do surgery. Secondary amenorrhea, again, Savage syndrome. So this could be thought of as being the other menopause. Pathology, you have unresponsive ovaries. This is a young patient who's going through menopause who shouldn't be going through menopause. Diagnosis is going to be such that the progestin levels is going to come up as negative. And the estrogen and progesterone challenge is going to induce a bleed. So if you have estrogen that causes the endometrium to proliferate, build, then you have progesterone that comes into play. That causes the progesterone causes the endometrium to shed, and that's basically the process by which menses occurs. And so you're going to want to try to mimic that to see if where the lesion is, or where the disorder is. Then, so you have in Savage syndrome, again, FSH and LH are going to be increased. And on ultrasound, you're going to see follicles. Treatment in this case is going to be supportive. And then if you have a patient, they could potentially be going through menopause, and you're going to have, again, unresponsive ovaries. A patient in her 50-ish year of life or is going to be going through menopause, and that's normal-ish. That's normal. Diagnosis is clinical, so you're not going to go through all of those things. It's part of normal aging. And then you can give venlafaxine for hot flashes for symptomatic treatment if that is required. Ablation, if we as the healthcare practitioners burned the endometrium, the patient could potentially result with amenorrhea that can come with, cancers, endometrial cancers. Then they need ablative therapy. Then they potentially will not have periods after that. Diagnosis is clinical. And then Asherman syndrome. Patients who have had either frequent surgeries or they've had elective abortions in the past, and some scarring results, and that's going to damage the endometrium, and that can potentially cause amenorrhea. And this patient is going to fail the progestin challenge. So they're not going to, if you give them progesterone, they're not going to bleed. And for that Asherman syndrome, there unfortunately is no treatment for that. So that was a full hour of talking. Feel free to let me know what you think. Let me know if you have any questions, comments, concerns, anything that I didn't cover that you want to hear, let me know. Um, I'm going to also be posting these videos on a new page. It's called Starters and Finishers. Um, Sometimes we might start some things and have struggle finishing. I know that that's a struggle of mine, and so but I'm going to be starting a new project called Starters and Finishers, and really the main premise behind that is that the word says that he who began a good work in you is faithful to complete it. And so whatever it is that God is calling you to start, he's also called you to finish it, and he has equipped you with the tools and the systems and support systems and that you need in order to finish that which you started. So as I finish my medical education, I am, grateful for all of you all for standing with me and standing by me. But hopefully we'll be able to help encourage other people to finish what God has started in their lives too. So be on the lookout for that. And then I hope to talk to you guys soon and see you on here in a little bit. All right. Love you all.